Of respiratory system, let me ask you guys, who's going to be responsible for hypoperfusion in the lungs? It's going to be the two main things that'll go wrong, right? Other than separation of the pleura. Hooray. Hypoperfusion, what's happening here? What will cause this? I'm so sorry. No cell phones in the classroom. Hypoperfusion. What two main organs are going to be affected or can be affected that'll decrease oxygenation to the body? Let me put it to you that way. This is a tough question. One causes hypoperfusion, the one causes hypoventilation. Let's start with hypoventilation.
So you're talking about the heart and the lungs?
Yeah, the heart and the lungs, right? So we need to make sure that we're getting oxygen in, carbon dioxide out, but we also need to make sure that we're getting blood from the heart to the lungs and back out of the heart into the body. So there's a lot of things that can go wrong here, right? A lot of things that can go wrong. So hypoperfusion. So the heart will be responsible for hypoperfusion. And a whole bunch of things can go wrong, right? Right ventricle, left ventricle, tons of stuff, right? Okay. Hypoventilation, it will be the lungs. And, we're going to walk our way through a couple of different things that can cause a decrease in ventilation, okay? So, once again, those defenses, those front lines, we're going to have that mucus blanket that's going to coat the respiratory passages that helps to provide a little bit of lubrication, but it also helps to trap foreign substances and hopefully push them back out, okay? And then it goes into our stomach and it's digested. Nasal hairs will act as cilia. They will help to filter particulate matter in the air to keep it from going down into our lungs. And then we have the actual cilia itself that are going to be on those respiratory epithelia, or those respiratory membranes. Signs and symptoms, this is all pretty straightforward stuff, right? Productive sputum, non-productive or dry. That's the worst, isn't it? When you have a non-productive cough. Much rather hack something up than not. Hemoptysis is going to be what? Bloody sputum. Okay, where are we going to see this? Who's going to present with this? Pneumonia, right? Especially if you damage some of those membranes. Where else? TB, oof, yeah, it's a bad one, right? Which it amazes me that people died from TB as much as 100 years ago, because it's just a bacterium. Cancers, right? Bloody sputum is not something to fool with. There's something serious wrong, right? Long-term smokers starts to damage the membranes, right? You could start to have leakage of blood into it. Dyspnea is going to be shortness of breath, difficulty breathing, usually due to decreased compliance, okay? Oh, it could come from anything, though. Decreased compliance, obstruction, okay? Cyanosis. So our blood doesn't turn blue. It turns to a deep purple. And the way that it transposes or it transmits through our skin or our mucous membranes, right? Because if somebody has dark skin, we would have to look inside the mouth, things like that. Is it looks bluish as it comes through the skin, that cyanosis. But our blood doesn't turn blue. That's kind of a misnomer. Have you ever heard that? I know people who are not really well versed in the body think that it's blue, but it's not. It's a deep, deep, deep purple. Okay. Hypoperfusion, heart failure, obviously. That's an easy one, right? So left side doesn't pump enough blood out to the lungs. It's not going to get the blood into the lungs to get the proper oxygenation, to offload the carbon dioxide. That's a bad thing, okay? It's going to back up. Oh, I'm sorry, I was thinking right-sided. Left-sided heart failure is going to have it back up into the lungs, okay? There's going to be stasis at that point. Stasis will prevent new blood from coming into the lungs and getting out of the lungs. Okay, do we understand what stasis is? It's backup. And if we back up the blood from the left side of the heart into the lungs, we can't bring new fresh blood into the lungs to get oxygenated. we create stasis, okay? Then that can back up into the right ventricle, okay, with left-sided heart failure. And then it'll back up into the body. So we get a pulmonary edema as well as a systemic edema because we'll have a backup of fluid as it's not being pushed forward through that system, okay? And that, of course, can lead to cor pulmonale, or that right ventricular enlargement and failure. Thromboembolism is obvious, right, in pulmonary vessels, and we're really fearful of that post-surgery, right? Reduced ventilation. So when there's reduced ventilation, there's a constriction of all the pulmonary arterioles. And there's a constriction because there's a sense that there's not enough what? Oxygen. They're not going to send as much, I should say pulmonary arterioles. I did. Oh, I'm sorry. I said pulmonary capillaries. Let me explain again. If you don't have enough oxygen in the lungs, you're going to actually start to constrict the pulmonary arterioles. You're not going to let as much blood get close to the alveoli because your body senses there's not enough oxygen anyway, okay? It's going to move it through the lungs more quickly and cause pulmonary hypertension. That's why when people get that emphysema, right, or the chronic bronchitis, they can get a pulmonary hypertension because we're going to constrict those arteries a little bit because we realize there's not enough oxygen in there. Are you with me with that? Okay, to get. Yes? No? Okay. So, reduced ventilation is going to cause indirectly a hypoperfusion. Thromboembolism, I forgot to tie it back. Thromboembolism is going to cause a hypoperfusion because it simply is not getting enough blood into there, right? Into those pulmonary vessels to get oxygenation. Hypoventilation. This is where we get into those COPDs. And like I said, your book, I don't know, what do you guys call them? Do you call COPDs still? Chronic bronchitis and emphysema? They would call them like CAO, like chronic, all these other different names. I don't know, maybe, I don't know. I just want to make sure I'm not missing the boat with something. I always learned COPDs. I think that's the most common terminology, okay? So chronic bronchitis, emphysema, airway obstruction. I'm going to walk you through all of these. Bronchial asthma. I think some people maybe don't link asthma in there because asthma can go away, right? There can be periods of remission with it, but it's still an obstructive airway disease because it will obstruct the size of those airways. Now, restrictive lung diseases, so we can get damage to the lung parenchyma or the lung structure itself. Those elastic fibers and the elasticity of the connective tissue that surround the alveoli and the pulmonary blood vessels can become slightly fibrosed or fibrotic. You can get a little bit of scarred tissue in there. And you can just imagine that would decrease lung compliance, okay? There has to be a little bit, there's elastic fibers in the lung for a reason. There should be some elasticity. If you damage that, they won't move or expand and constrict as well. And that would inhibit the ability to get air in, but also getting it out, right? If you're not compressing it out as effectively, okay? Severe kyphosis, right? Which is gonna be what? That hunchbacking. Do you guys remember kyphosis and scoliosis? Okay, that severe hunchbacking. We had a patient who was so hunchbacked, he literally had to hold his head up. You know, so if you have that much, I've seen people where it's almost a right angle kyphosis. It's crazy, okay? Well, that kyphosis or that extreme, people at home, I'm sure this is review, but that kyphosis is that hunchback. Well, there you go. Do it yourself. I just felt it. You know, if you decrease that lung capacity or volume, you're not going to be able to breathe as well. Severe scoliosis as well. That becomes, when you have a scoliosis that's above 40 degrees, okay, it's a surgical consult because it can actually put pressure on the lungs and also on the heart. Because when you have that curving, you also get what? A decrease in height. My stepdaughter has a pretty pronounced scoliosis. She'd probably be 6'4" if it weren't for her scoliosis. It's pretty bad. It's between 20 and 30, I believe. But they braced her. She's done really well, and I think that it's actually decreased as she's gotten older. Okay, so hopefully it's a little bit. I need to ask her about that. But anyway, you just don't have as much room. Okay, so that would be considered restrictive as well. Severe obesity, right, is going to actually cause some compression in the lungs and inhibit the ability for the lungs to get air in as well. Muscular dystrophy, unfortunately, is going to cause a weakness of those respiratory muscles. Lou Gehrig's disease can cause a weakness of those respiratory muscles as well. Botulism, okay, botulism. They always tell you not to eat a can that's what? Blown out, because it can have botulism in it. Okay, Clostridium botulism, is it botulinum? I think it is. I'm totally going off notes. I'm just giving you some examples. And botulism is also what they do the injections with now, right? Right. So, which blows my mind. You know that they're finding traces of it in the olfactory nerve, those botulism injections. They use botulism is going to cause paralysis of muscles. So somebody had a great idea to do injections on the face so you don't do what? Express yourself as much, and then you won't have as many wrinkles. Well, they're finding that it's finding its way to the olfactory nerve, right? Not that far. And the olfactory nerve has a direct link to your brain. So I'll be interested to see what happens in the future with that. Hopefully nothing. Anyway, so botulism can cause paralysis of the diaphragm as well. Okay, so that would be obviously restrictive lung disease. Like, a little bit of a tangent there. Fibrosis of the lungs due to autoimmune disease, okay, infections, drugs, etc. Okay, so let's go through some of these. So COPDs, exemplified, let me bring people at home back in, okay. Chronic bronchitis and emphysema are going to be like the two biggies, right? So let's talk about some of the mechanisms that happens with those. They're irreversible, okay, and it inhibits their ability to breathe in and out. History of smoking, that's a big one. It just blows my mind that so many people still smoke. Dyspnea, coughing, frequent pulmonary infections, right? Because their membranes, the inside linings, are not as healthy. And don't forget that those lining membranes are going to provide a barrier, an area of protection. There's macrophages, there's the cells themselves, there's that mucus blanket, there's the cilia. In smokers, all of those are damaged. Okay? All of those front lines are damaged. So they can develop respiratory failure. Okay? Respiratory acidosis can happen as well from a buildup of carbon dioxide, Now, alpha-1 antitrypsin is a substance that helps to maintain the elasticity of the lungs. Okay, alpha-1 antitrypsin. Do I have this in the notes? I would write this down. Okay, alpha-1 antitrypsin helps to maintain the elasticity of the lungs. So as long as you have healthy lungs and you're a non-smoker, you have alpha-1 antitrypsin, and it helps to maintain that elasticity of the connective tissue in the lungs. Okay. People who smoke have lower levels of this alpha-1 antitrypsin. It gets damaged, okay? And it can lead to, chronic bronchitis or emphysema. But there are people who also just inherently have alpha-1 antitrypsin deficiency. So they don't have this substance to maintain the elasticity of their lungs, and their lungs can be damaged, okay? It's a genetic disorder. Alpha-1 antitrypsin. Okay. Okay. So it can be due to smoking, or it can be just an inherited disorder, alpha-1 antitrypsin. Either way, patients can get chronic bronchitis or emphysema. I have some pictures about this, and can lead to ventilation problems. And air pollution too, I should mention, other than tobacco smoke, air pollution. And what happened like 100 years ago that damaged lungs? I've actually seen one or two, believe it or not. Yeah, coal miner's lung, it is nasty. Okay, it is black. It is the color of my pants today. Okay, coal miner's lungs, and it just infuses into all those tissues of the lungs. Okay, so in addition to tobacco and the alpha-1 antitrypsin deficiency, it can also be air pollution. It can be coal miner's lungs, which we don't see in youth today, thank goodness, right? Nasty job. Okay, So bronchitis, bronchiolitis as well, right? Could be inflammation of the bronchi or the bronchioles. Cough with lots of phlegm, that's going to be the main thing. You're going to see the phlegm in there. It can be acute. I tend to get this every fall, knock on wood. Knock on wood, I haven't gotten it this year. But I was also, just as a little side note, I kept getting bronchitis until the past 3 years. And my nurse practitioner, when I had like the 5th episode last year, she's like, well, something's up. You know, I'm an asthmatic, so I'm prone to it anyway. Well, it turns out that I had black mold in my office here. That's why I don't have an office. That's why I meet you guys here, if you need to meet with me. And that black mold kept aggravating, and I kept getting bronchial infections. You know, so an acute bronchitis can be from being sick, but also it can be from some sort of infectious agent like that. Thank goodness she mentioned that. Okay. Yellow white phlegm, we know this, right? You know, the whole blue bloaters. Do you guys ever hear that? Pink puffers, blue bloaters. I don't know. Okay, some people say people are blue bloaters because they have cyanosis and they tend to get, with this chronic bronchitis, some difficulties with the heart. Okay, so they get cyanosis. And then pink puffers tend to be oxygenated well, or with like asthmatics, I think it's linked in. But you can get this presentation in either of these groupings. Okay, so I think this is sort of an antiquated term. And emphysema or pink puffers, okay, I don't know. It's kind of an antiquated term. But anyway, the difference was, so chronic bronchitis is going to affect the bronchi and the bronchioles. It's going to cause a production of the phlegm, okay, coughing up with the phlegm, difficulty breathing. It's going to be obstruction, right? Because the bronchioles are going to have an excess mucus deposited on them. Emphysemas, or people with emphysema, are going to have damage to the alveoli. Now, what happens to the alveoli with people with emphysema? Does anybody know? What actually happens? What's the pathology of this? I can tell you, it's to the alveoli. They can collapse. I mean, bring it one step before that. So airways can collapse during expiration. One step before that, what starts it? What's the actual mechanism? Okay, so if you imagine those grapes of alveoli clustered together, you actually start to break apart the membranes between the alveoli. So if you break apart, so once again, we have 300 million alveoli in the lungs. If you start, and the whole reason we have 300 million is to increase surface area. We want a lot of these really small alveoli, so we have tons of surface area. So we're able to bring capillaries around them, and we're able to quickly and efficiently exchange gases. Think about it, you know, 12 to 15 times a minute you're breathing. It's quick and efficient. That's amazing, really, right? So we have to have tons and tons of surface area. I think they say if you spread out, you know, a lung, it covers the surface area of a tennis court or something, you know, if you break all those membranes down. I could be wrong, but it's about that, okay? If you start to break apart the walls of the alveoli and destroy them, you're going to decrease surface area. You're not going to be able to exchange oxygen and carbon dioxide efficiently. You're also not going to be able to keep those alveoli open as efficiently. So with exhalation, they'll collapse, okay? They'll collapse. And air can't get out, it gets stuck. If you were to actually look, hopefully, if we do this cadaver, well, I'm definitely going to do the cadaver. So please keep in touch with me. I'll try to contact you. I think I can keep your emails, but if you have a patient with a lung that has emphysema, I mean, it's like, it's a very squishy sponge. When you feel it, you can feel those pockets of air in there. They get trapped. It's pretty amazing. Okay. So usually, obviously, going to be induced smoking, air pollutants as well. Okay. So asthma. So those bronchioles, if you can imagine, you know, those tubes get smaller and smaller. We get down to bronchioles, and bronchioles are going to have smooth muscle around them. What happens with asthmatics is some sort of trigger, be it emotional, be it chemical, you know, be it some sort of allergic response or autoimmune. those bronchioles will constrict and they can't get air out. And what do they say it feels like? It feels like you're breathing through a really small straw. Yeah, it's awful, awful feeling. Okay. So we give them steroids, right? And steroids are going to stimulate fight or flight. If we move into fight or flight, we're going to want to open up those bronchioles so we can get more air in. And that's why, you know, with some of those inhalers that are steroids, they tend to get an increased heart rate. I know that I get like a very sympathetic response when I have to take my rescue inhaler. You know, heart rate goes up, you know, things like that. Okay. So what condition would this be about? Well, look at the inside. I agree that it's constricted, but what's on the inside of that tube on the right? So normal's on the left. On the right, we see it's going to be constricted. It's actually going to have a thickened basement membrane, and it has mucus on the inside. Okay, so this is representative of a chronic bronchitis. In addition to the mucus, we tend to get irritation to those passageways, those bronchioles, and they tend to get a little bit thickened in response to irritation. Okay, so chronic bronchitis. So mucus deposition and a thickening of that membrane, of the membranes underneath. Now, what condition is this? That's not mucus on the inside there, by the way. Like a little reflection. Although you can get mucus with asthma, can't you? Okay. This is asthma. I just give away. So this is going to be asthma. The thing about asthma, though, is that it comes and goes, right? Chronic bronchitis is going to be more persistent. That's going to be the big difference. Okay, that's going to be the big difference. Now, if asthma is not treated effectively, though, you can also have it turn into permanent damage, okay? But the difference really is that asthma with treatment will go, okay, will remit. And then what condition would this be? This may be hard for people in the classroom to see. This is a great picture because on the left is normal, on the right side is abnormal. On the left, we can actually see those alveolar pockets, the little pockets of the alveoli. And on the right, you can see that those septa have been destroyed. Okay, so we're looking at a little acinus there, a little functional unit of the lung. And that little acinus, all the little separations between the alveoli are destroyed. Now, if you get rid of those walls, you're going to decrease surface area too. Okay, good. Pneumonia, I think we're all pretty familiar with this, right? Some sort of infection happens, can be viral. Viral will turn into bacterial. We'll get infection into the stroma, the structures of the lungs. Okay. Cough with phlegm will be another thing as well. Here's a little picture. It's obviously where the box is. I always find the best pictures always have pointers or boxes on them. I put them up anyway. Okay. That should be good bread and butter stuff. Acute respiratory distress syndrome. Let me ask you guys, do you see a lot of this? ARDS? Or some? Because like the book went on and on about it. Is this something that's pretty common, or is the book just like latching on to a topic that...
I mean, I've seen it.
Yeah.
Or pneumonia or COPD.
Okay, okay. Well, anyway, some sort of damage will happen to the epithelium of the lung or the lining of the lungs, okay? And that damage allows exudate, okay? It's going to be to multiple areas. It's not like a little bit of an infection gets into one little lobe and, you know, you get pneumonia there. This is going to be more of a whole lung kind of problem. So the epithelium is going to get damaged. A lot of inflammation will go to that area. And now you cannot get the transmission of oxygen and carbon dioxide between the alveoli and the pulmonary capillaries. That's the gist of it. Okay, that's the gist of it. Yeah, the book just went on and on and on. I'm like, oh, maybe I should go over this. I don't know. I'm sure people at home have probably seen this, okay? Very life-threatening, okay? You've got to obviously treat them, but the thing is, if you give them too much oxygen without removing the cause of the inflammation or the damage, what's going to happen? You're going to oxidize the lung tissues and you could cause damage there if it's just going to sit in the lungs. So you got to get rid of the problem, whatever that problem may be, whatever the trauma is, the infection is, you got to get rid of it, okay? So you get a buildup of fluid in the air sacs and also in that connective tissue. I think that's an important thing to understand, Okay, so you can't get the oxygen and carbon dioxide across. Can cause failure of other organ systems, or other organ systems, I should say, fail as a byproduct of whatever the initial damage is. Okay. Difficulty breathing, obviously, acute onset. Okay. So I don't know. I don't know if that's a big thing that people see a lot or not. Tuberculosis, thank God we don't see this. Who do we see this in, though? Tuberculosis. Who do we see this in? People who are immune compromised, travelers, right? Okay. It's bacterial, though, so if it's caught early enough, it's treatable. It's such the sad thing. I'm such a dork. I watch all these ghost shows, and they go in these, explore these ghost places or whatever. And a lot of them are old TB wards, because just tons and tons of people used to get TB, and before we had antibiotics, they couldn't do anything. So Mycobacterium tuberculosis, it's airborne, of course, right? So, when people cough, it's easily transmitted. It forms a focus in the lungs, and it can form foci through other areas or tissues of the body, and you get this granulomatous infection in there that gets walled off, and it becomes caseous. Remember caseous from the very beginning? It's that cheesy-like presentation, but we also like to wall it off with a layer of calcium. One of the cadavers that I worked on, years ago, you could feel them. We thought, it was walled off, old TB infection, and it was this crunchy, I can't imagine what else. I know, it was really kind of gross. Somebody made a gross face. We felt it in the lungs, and we could feel like 3 or 4 of them. So if somebody is infected with it and they get over it, they can have these deposited areas of these dead, walled off areas that the body has tried to encase this tuberculosis infection. Okay, so coughing, fever, night sweats, weight loss. We know this, right? The rest of that. So there's that granuloma, that deposition, okay, into the lung tissue. And once again, if they get healed, they wall it off with calcium, and it forms this little nodule. Okay, botulism. Oh, I do talk about this. Okay, botulism, undercooked food. Okay, it's found in cans you're never supposed to eat food in a can that is expanded. And the bad thing about botulism is it likes to paralyze the phrenic nerve. And the phrenic nerve is going to be the main nerve that goes to the diaphragm, okay, and causes the diaphragm to work. So botulism is a very, very, very fatal disease. Or it's really good for facial wrinkles, one or the other. So lung cancer, we have different types of lung cancer. Do I go into I do, okay. Abnormal growth. This is just such a scary thing, and I think we're seeing more. The thing that's scary about it is that we're seeing one of my students, she was in her mid-30s, died from lung cancer, and quickly. It was May. It was right after classes were out. Nice young lady, 2 young kids, emailed me. They found a tumor in my lungs. They're going to take it out, whatever. And she was dead by June. Just get a chest film. And she was non-smoker. No history of being exposed to any chemical agents. Go get a film. Ask your friends to x-ray your lungs. Make sure they're clear. It's scary to me what happens. Of course, there's a strong association with smoking. There's also areas of the country. Did you guys know that Seneca Falls, where I actually went for my doctorate, is a high area for breast cancer, which is kind of weird. Secondhand smoke, radon, etc., chemicals, okay? So, we all know these signs and symptoms. Persistent cough, hemoptysis, chest pain with a cough, okay? So, 3 different types. We are going to have a squamous cell, okay, small cell, also known as oat cell carcinoma, because it looks like oats microscopically, and then adenocarcinoma. So squamous cell and small cell, I believe, are going to be closer to the primary bronchi. So they're going to be more centrally located. Okay, they're going to be more centrally located, as opposed to adenocarcinoma, which is going to be in the periphery of the lungs. Okay. Small cell or oat cell is going to like to metastasize to the lymph nodes, because if you think about it, it's near those primary bronchi. There's a lot of lymph nodes there. Okay, and it likes to metastasize to those lymph nodes. It gets into the lymph system and shazam, you know, it likes to metastasize. Okay. So, I don't know, nasty stuff. Lung cancer makes me so sad. So, congestive heart failure is obviously going to cause problems as well. Because if we can't get the blood into the heart or into the lungs to get oxygenated, that's going to be a problem. Okay. Fluid will back up from the left heart into the lungs, and then eventually can go to the right heart as well. Got to reduce the fluids, figure out the problem of what the congestive heart failure is, right? All bread and butter stuff. Should sound pretty familiar. Cystic fibrosis, such a sad condition as well. Okay, it's going to be the production of excessive mucus, but that mucus also has less water in it. So it's more like viscous. That's not even quite the word. Yeah, I guess viscous would be the right word. You know, when we produce mucus, we have some fluid or water in it, so we're able to hack it up and get it out, or we're able to move it along the digestive tract. Okay, so I'm sorry, I'm getting all sorts of texts and phone calls today, and it like throws me off my game. So I tell everybody, leave me alone during class. No, I'm just kidding. So cystic fibrosis, this isn't inherited. This is going to be congenital genetic defect. Okay, and where it likes to manifest is it produces this thick mucus in the lungs that they can't get out. That's where you do the what? The back tapping, the cupping, right, to try to get it out. But it also plugs the where the pancreas secretes the digestive enzymes. It likes to plug there as well. So the two major areas that it plugs is where the digestive enzymes come out. So they tend to be really thin, right? Because they keep all those macronutrients in their GI tract and they excrete them rather than breaking them down and absorbing them. So they need to be given digestive enzymes orally. But the other problem is that mucus can block the lungs and they can't get it out. So they have difficulty breathing because it'll stay in the lungs, right? Okay. So physical therapy to dislodge that mucus and keep the airways open. If that mucus lodges in there, and if mucus lodges in there for any reason, it can close those air passages, decreases airflow, it can cause a collapse of those alveoli, it can cause all sorts of problems. Okay? Very good. That was just about as long as I thought it would be. That worked out well. I was going to add more than I thought. I think that's plenty. Any questions, please let me know. Once again, I think it's really good to have a strong recognition of the A&P. I think that just you can work your way back from that, okay? Next week is going to be GI. I already have the A&P lecture up for GI, but I am going to be redoing it with quite a bit of it, okay? So GI and hepatobiliary probably will be doing. Any questions? Awesome. Well, guys, thank you. Sorry about the delay. I don't have any music loaded this time, so I'll let you go quietly, contemplatively. All right. Thank you.